All right, we'll go ahead and call the meeting to order. This is the Senate Standing Committee on Health and Welfare. This is meeting number 8. The date is Wednesday, March the 2nd, 2022. Madam Clerk, please call the roll.
Senator Adams. Senator Berg. Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howell. Senator Kerr. Senator Nemes. Senator Wise. Senator Meredith. Chair Alvarado.
Here. All right, we have a quorum and we're established to do business. We're going to go a little bit out of order here for bills to consider. The first one we're going to consider is House Bill 188, an act relating to telehealth. The sponsor is Representative Jim Duplessis. I know, Representative, you've got some guests online as well who are at a bit of a time crunch, and so we thought we'd address this bill first in their, out of respect for their time. If you'd like to introduce yourself and any guests that you have, and then please begin your testimony.
Thank you, Mr. Chairman. And yes, this bill, I'm Jim Duplessis, State Rep, District 25. I'll introduce my guest here in just a second. She's standing by in case any questions come up. Her name is Dr. Cheryl Levinson, and she's an associate professor at the University of Louisville, as well as the head clinician at the Eating Recovery Clinic in Louisville, Kentucky. This committee, and Chairman, you especially, have been leaders in telehealth for our state, and I think that this is a bill that will really take us to that next step for a few that got left out of other bills. So, Dr. Levinson, if you'd like to introduce yourself.
Hi, everyone. I'm Dr. Levinson. As Jim said, I am the clinical director at Louisville Center for Eating Disorders, and so oversee many clinicians seeing patients virtually and in person now, and also a professor at University of Louisville. And I'm happy to be here to answer any questions about the bill.
Thank you. So, Mr. Chairman, very briefly, a constituent came to me that was a patient of her clinic. That patient was going out of state, and the clinic wasn't able to see her while she was out of state because of the way the law is written. It covers medical doctors but not licensed therapists. So this bill allows folks who are receiving mental illness, and we've seen with COVID, mental illness is a real thing, and we've seen that telehealth can be very beneficial to those who need a helping hand. And so this bill will allow a clinician, if he or she is out of state, if their patient's out of state, to do so. It also has the ability for other states that are, if they have one of their residents are living in are visiting our state, they could receive services as well, reciprocity. So, Mr. Chairman, I'd be happy to dig into it, but if there's any questions, it's pretty simple. It just allows folks who are receiving mental illness from a certified and licensed professional in the state of Kentucky to receive those benefits. That person must be a permanent resident of our state. They can't be somebody who is a non-permanent resident. Mr. Chairman, you did have an addition that you added to the bill, and I don't want to speak for you, but my understanding is that you wanted some definitions to be done by the cabinet as to what temporary means, because temporary could be a university student that's in Ohio, going to Ohio State or where have you, and that student might need some help. Could they receive it since they're temporarily living in Ohio? That would be something that I guess the cabinet needs to define. And so, except for that definition, everything is in there. So, any questions?
Thank you very much. I'll just, for the members of the committee, we do have a sub on this. It's PSS 1 before you. The changes in that are, as the sponsor has said, that there's under Section 2, it's to require the cabinet to promulgate regulations to define temporarily located. And so you'll find that language in Section 2. And then also in Section 3, there has been some renewed issues this past interim and during this year. We've had some discussions with the Department of Insurance. One of our particular MCOs has been interpreting, I think, the law that's currently written incorrectly. Had discussions with them. They held to their interpretation. So we put in some language here to make sure that we told them exactly how it needs to be interpreted. And so if you look under Section 3, it says for the purpose of this section, equivalent has the same meaning as Section 4. And then Section 4, its equivalent means reimbursement in an amount equal to what reimbursement would have been had the service been furnished in person by that provider. So right now, if you're doing telehealth, if you're doing a service, you're seeing somebody in the office, let's say for a blood pressure follow-up, it's a level 3 visit. The way we drafted the language, I thought was clear that if you provided that same service through telehealth, you'd be reimbursed the same as you would in your office. One MCO in particular said that's not how we interpret it, so we are making sure that this is very clear that that's how it needs to be interpreted. And those are the primary changes in the sub. With that, I would entertain a motion. You have a motion. Is there a second? All those in favor, please signify by saying aye. Aye.
Aye.
Any opposed? All right. The motion is the sub is before us. And any questions from members of the committee on the bill as amended? Senator Carroll.
The last, Representative Duplessis, thank you for bringing this bill. The last comment you made about reciprocity, we've had some conversations, Mr. Chairman, about this, and so this will allow services within the Commonwealth for people who may live in another state and they telehealth into the Commonwealth.
Okay, so it simply means that, let's use the state of California, for example. If a California resident is visiting our state for whatever reason, if they have a telehealth need while they're in our state and they're a permanent resident of California and their clinician is, and their provider is in California and a permanent resident of California, then they would be able to receive telehealth, which is simply a reciprocity of what we're asking for, so that a Kentucky resident, when they're out of our state, can get services from a Kentucky provider. So if we're going to allow it in our state, I'm told we also have to offer reciprocity for other states.
And I know there are some agreements with other states in dealing with that, Mr. Chairman. Correct me if I'm wrong, because I know families within the state of Kentucky. There is a particular doctor that used to be in St. Louis. She moved to Texas, and they were able to do telehealth through COVID, but that has stopped, and they're unable to do that. So is that a direct agreement that would have to be made with that state, Mr. Chairman?
Correct. We have interstate compacts, which can be part of that. Texas is particularly difficult, unfortunately. In terms of getting licensing for providers there, it's a very rigorous process. They're not part of a lot of the compacts that are there. Of course, the way we've got our telehealth laws drafted now, that you can be as long as you're licensed in the state of Kentucky, you can be anywhere in the world. As long as you're licensed, you can provide that service to a person from Kentucky. So if they're interested in getting a license, they can get one and provide that service.
Excellent. Thank you, Mr. Chairman.
Thank you. Any other questions? Senator Givens.
Mr. Chairman, thank you. And you and I had a conversation about the meaning of the word equivalent, and state again for me, the challenge has been specific with commercial providers.
There's one particular MCO.
Right.
Yes.
And so the language as it relates now, putting the definition of the word equivalent, clarifies what we see, I think, on page 6. Telehealth coverage and reimbursement shall be equivalent to the coverage for the same service provided in person unless the telehealth provider and the health benefit plan contractually agree to a lower reimbursement rate for telehealth services.
Can you direct me which line you're
Sure,
looking
yeah.
at, page 6?
Page 6, line 13 in the sub. So we've defined the word equivalent. I think the scalpel approach you've taken, Dr. Alvarado, is perfect. We've defined the word equivalent, and now we're saying a health benefit plan, starting in sub 2, telehealth coverage, I'm on line 13, and reimbursement shall,
It's perfect.
except as provided in B, be equivalent to the coverage for the same service provided in person unless the telehealth provider and the health benefit plan contractually agree to a lower reimbursement rate for telehealth services. I think you've crafted it perfectly. Staff has crafted it perfectly. Share with me what this provider was saying.
I think the way the law, that what you're reading is current law, what's what we've passed before in our telehealth law, I thought it was self-explanatory. But there was somehow an interpretation from one of the MCOs in particular that they could reimburse people at a lesser rate based on what they were paying other providers or something along those lines. And again, if they want to, an MCO right now could contract with a provider that if they want to have a contract that says if you're going to provide telehealth services, we will reimburse you at this rate or a different rate, and then that's a contractual agreement between the provider and the MCO. But they were interpreting that somehow that they could pay less for that visit. To me, it didn't make sense. We didn't hear that same argument from the other MCOs. We had interactions with them, a meeting with them, a meeting with the Department of Insurance to discuss this. DOI thanked us for bringing it up to see if they wanted to do anything, but we thought since this bill was coming, it would be easier just to make that clarification to make it very clear in the law.
Quick follow-up, Mr. Chairman, if I could. And so in section 3, where we are connecting the definition of equivalent from one section to another, maybe staff or someone can show me, is the word equivalent also used in section 3 somewhere? Ben, would you know?
Page 4, line 1.
All right.
It says, within the Department of Medical, so if you go back to the previous page, on the bottom of page 3, within 30 days after June 9th, 2021, promulgate regulations in accordance with Chapter 13A to establish requirements for telehealth coverage and reimbursement rates which shall be equivalent to coverage requirements and reimbursement rates for the same service provided in person unless a telehealth provider in the department or a managed care organization contractually agree to a lower reimbursement rate for telehealth services.
Excellent. Thank you, Mr. Chairman.
Thank you. Any other? Yes, Senator Ms. Meredith, please proceed.
Thank you. And Chairman Alvarado, this question may be for you as well, because reading through the bill quickly, is there any provision to require that the patient already have an established relationship?
This is all existing language. I'd have to go back and review. My understanding is that it did not require an established relationship. It's particularly when we first had drafted this, was that, and again, that's all existing statute. Current, nothing is being changed in this bill from that.
Well, yeah, I appreciate the bill sponsor. This is an evolving issue, and I think probably we'll see several more bills in the future trying to clarify what this is. But the reason for the question is, I don't want to get in a situation where, using your example, in California, sets up a bank of providers and say, anytime you're in Kentucky, feel free to telehealth and be in competition with local providers, even though they don't have an established relationship with the patient. So I don't know. That's an issue. I'm certainly not going to stop.
Mr. Chairman, if I could, and Senator Meredith, I appreciate the thought, but if you kind of peel the onion back, the reason for this bill was for mental illness, because its current law doesn't allow for licensed therapists to do telehealth, licensed and certified, that is. This bill simply allows that. Current law would already allow a doctor to do that. So if you're seeking mental health, that's going to be an established relationship issue. It's not going to be something where you would say, well, I'm going to call Joe Schmo back in California. If you're in Kentucky and you're having mental illness issues, you're not just going to randomly call somebody you don't know. That's a relationship anyway when you're dealing with mental illness. That's something where you've created a bond with your therapist, which is why it's so important to be able to maintain that bond when you're away from your state with that therapist, because they know the history of your illness. They know the history of where what's caused triggers and all those different things.
I agree with you, and believe me, not trying to throw any roadblocks in your way or be argumentative, but with the shortage of mental health workers in Kentucky, I mean, if you have an episode that previously been undiagnosed or you haven't suffered from, and you need coverage, again, using your example, I know it's a weak example, but you're from California, you have this episode, you can't find coverage in Kentucky with any provider. Can you reach out to California? And again, I don't think it's a big problem.
So, Senator,
about going forward.
The same holds true. That Kentucky resident who's no longer in the state, instead of calling, if they're in California, instead of going to a California doctor, by your example, could call somebody back home. So it would maintain that relation, that contractual obligation that you're talking about. So it's still the same number of people in our state that a provider would be taking care of. If you're out of the state and you need some help, you could call somebody, even if you don't have a relationship. So that would work both ways, correct?
Possibly. And again, I'm just looking at how these things get manipulated by so many people. And You know, I just hate to see a California company set up a 1-800 call us, and I don't.
If that happens,
I don't
we
think
can
it's an
address
issue
it.
today, Representative. I truly don't, but just trying to think about how it could be manipulated in the future to really not to the patient's advantage or could take the provider's advantage. But again, that's just another conversation for another day. But thank you, appreciate it.
And I think just that issue, I think that's where the definition of temporarily located is going to help in that situation. If someone's spending a lot of time, or I think hopefully the cabinet will be able to define that. Senator Givens, another question. No? Okay, very good. Any other questions from other members of the committee? If not, we'll entertain a motion on the bill. You have a motion. Is there a second? Second. Any other questions or discussion? Madam Clerk, please call the roll.
Senator Adams? Senator Berg?
Aye, and thank you.
Senator Carroll? Senator Givens? Senator Harper Angel? Senator Howell? Senator Kerr? Senator Meredith? Senator Nemus? Senator Wise? Chair Alvarado.
Aye. The matter passes unanimously with a vote of 10-0. I think we're starting to consider motions for consent, if there's a motion. We have a motion. Is there a second? Second. All those in favor, please signify by saying aye.
Aye.
Anyone opposed? Very good. Congratulations, Representative. We appreciate you bringing this forward. And like I said, every year I think we're going to start seeing hopefully new clarifications as telehealth continues to expand and the need is there. And I think Kentucky is probably one of the leaders, fortunately, on this front. So we want to continue to improve it. We appreciate your efforts.
Thank you, Chairman and committee.
Next on the agenda, we're going to take Senate Bill 173. This is an act relating to medical order for scope of treatment. The sponsor is Senator Jason Howell. Senator, if you'd like to come to the table, introduce yourself, any guests that you might have, and begin your testimony.
Thank you, Mr. Chairman. Jason Howell, Senate District 1. I have Lori Earnshaw, who's a senior hospice physician at Hospice Health, online, I believe, to answer any questions if we get too deep in the woods. In essence, in the 2015 legislature passed the most bill, the medical order scope of treatment to deal with being able to better handle end-of-life healthcare issues. It's worked real well, but as we've gone on and moved more toward online medical records, as you well know, Mr. Chairman, there's been a need to take this form out of the paper world and put it into the digital world. So this bill provides that. It gives the KBML the authority to develop the online form to match the paper form. That way, there's more transportability with the formatting and the form to follow the patient a little easier. And it seems to be in line with where we're going with the handling of medical records. Another change in this is it allows this form to be translated into different languages to handle the more diverse backgrounds of our citizens. I'll be happy to answer any questions. I'll be happy to go into the weeds on most, but that's a pretty well-established situation now, so I'm trying to be cognizant of time. I'll be happy to answer any questions anybody might have.
Thank you, Senator. Thank you, Senator. We have a motion. We have a second. Any other discussion, questions from members of the committee?
Could I make a quick comment?
Yes, please, Senator Burke.
I would really like to thank the committee and the senator for bringing this forward. I can remember when we were propagating this type of information, and it was, on the front of the chart. And the problem is the chart doesn't go with the patient anymore. It used to be a Joint Commission rule. Chart stays with the patient. It's now electronic, and when that patient gets transferred, that those papers can get lost, and then you're talking about starting all over again with very difficult discussions and trying to get the information passed on to the next facility where mistakes can be made because they don't understand or don't have good documentation of the family's wishes. So I think this is a wonderful bill. I urge everybody to vote yes. Thank you.
Thank you. Any other comments? Madam Clerk, please call the roll.
Senator Adams? Senator Berg? Senator Carroll? Senator Givens? Senator Harper Angel? Senator Howell? Senator Kerr? Senator Meredith? Senator Nemus? Senator Wise? Chair Alvarado.
Aye. The matter passes with a vote of 10-0. We'll entertain a motion for consent. You have a motion and a second. All those in favor, please signify by saying aye. Anyone opposed? Very good. The matter passes unanimously. Senator, congratulations, and it'll be on consent calendar for the Senate floor.
Thank you, Mr. Chairman, members of the committee.
And last on the agenda will be Senate Bill 178, an act relating to certification for clinical supervisors of alcohol and drug counselors and declaring an emergency. The sponsor is our very own Senator Julie Adams, Rocky Adams. Senator, if you'd like to come to the table, introduce yourself, have your guests introduce themselves, and please begin your testimony.
Thank you, Mr. Chairman. Julie Rocky Adams, District 36. And it was really, I think, appropriate when you said that for the telehealth issue that we can expect, people to come back session after session to update these things. Well, I don't think it would be an appropriate session unless we had an update on our alcohol and drug counselor regs. And so I will let my guests introduce themselves.
Hi, I'm Jessica Burke. I am the Senior Vice President for Legal and Government Affairs for Addiction Recovery Care.
I'm Tim Cesario. I'm the Chair of the Kentucky Board of Alcohol and Drug Counselors.
Please proceed.
Thanks.
Go.
So thank you for having us here today. This is, as you can see, a fairly simple bill. It's about 2 pages. So last year we had Senate Bill 166 that did 2 main things. It created a licensed alcohol and drug counselor credential that Kentucky did not have before, and that is for folks that have a 30 hours master's degree. So that was a fantastic addition to our repertoire of people who can treat people with substance use disorder. It also created some different requirements for the credential of certified clinical supervisors. That bill went into effect in March of 2021, and that bill gave the board between 90 days and a year to require all clinical supervisors to meet those new requirements. As everyone is aware, the last 2 years have been a little unusual. So what we're facing now is that we're not going to have supervisors that are required unless we can grandfather in some supervisors that we already have. So I will turn it over to Mr. Cesario as chairman of the board. But basically all this new bill is asking is that we be permitted, we being the board, not providers, the board be permitted to grandfather in existing clinical supervisors for a short period between 90 and 100 days, or 90 days and a year. And then after that, all new clinical supervisors would be required to meet the new requirements.
Okay, so that would affect approximately 444 approved supervisors who were approved as of March 24th, 2021, when Senate Bill 166 went into effect. Currently, we have 543 supervisors in the state. If we don't make this change, or if this change isn't approved, the potential is there for us to be reduced to less than 100 supervisors across the board. Okay, so in essence, making this change to the statute would promote workforce development, because right now we have approximately 2,000 people that need to be under supervision with temporary credentials. We would have less than 100 supervisors to supervise nearly 2,000 people if we aren't able to grandfather people into the clinical supervisor's credential. So, and when I discussed this with LRC, they suggested that we put the emergency regulation in this.
And any questions? We'll be
Very
happy
good.
to-
Well, thank you very much for your testimony. It seems like, again, a pretty straightforward bill. Any questions from members of the committee? We have a motion on the bill. Is there a second? And a second. Any other discussion or questions? If not, Madam Clerk, please call the roll.
Senator Adams, Senator Berg, Senator Carroll, Senator Givens, Senator Harper Angel, Senator Howell, Senator Meredith, Senator Nemes, Senator Wise, Chair Alvarado.
Aye. The matter passes unanimously with a vote of 10-0. It's eligible for consent. Do we have a motion? We have a motion for consent. Is there a second? We have a second. All those in favor, please signify by saying aye. Anyone opposed? Congratulations. The matter is referred to the Senate floor on consent calendar, and appreciate your efforts. I want everyone to notice the time is 10:25. I think that might be the quickest health and welfare meeting we've had. Any other matters before this committee? If not, we will stand adjourned. Thank you.